But I think, you know, getting away, that's called a split treatment model is what that's called, where this treatment is split between two people. And it's not always the best thing. I mean, think about it with regular medicine, right? How hard is it for your family doctor to keep track of all the specialists that you see? That's difficult. I mean, they do the best they can, but it's difficult to do that. Now, you know, what did Dr. X start you on yesterday? And what labs did Dr. Y do on you last week? And you know, that's difficult to keep up with, especially in this day and age. Eventually, maybe things will be on the internet, and you'll be able to type in your Mrs. Smith, and boom, all of the labs and all the meds and everything is all in one system that all doctors can access. But at this point, we're not there. So, with this split treatment model, I sometimes fear, and I see this. I'll see patients refer to me that have seen a whole bunch of psychiatrists. They've tried a lot of different medicines, and nothing seems to be working. And they'll come to me with treatment-resistant something. Treatment-resistant depression, treatment-resistant bipolar disorder, whatever it may be, anxiety. And invariably what ends up happening is that the psychiatrist hasn't really had the time to spend with that person and really get to know what's going on. And so let me give you kind of an idea about that. And when I was in practice, part of the reason I left practice is because they were pushing us to go into the 10 or 15-minute med check model. You know, at the time I was doing 30 minutes, and sometimes it'd take me even longer. I'd 45 minutes or so on a follow-up appointment. Okay, I tend to like to hear all about what's going on with the patient before I make decisions on medicine. And once I make a decision on a medicine, I want to tell the patient exactly what to expect with the medicine and the illness, what to expect with the illness, and how are they going to improve. If you don't set the person up for success, you're not going to have success. So if you don't explain, hey, this is an antidepressant, it ain't going to work overnight. You're going to get a call 2 days later saying, Doc, you started me this 2 days ago, it ain't working. I'm going to say, I should have told you probably, but I didn't. It takes 10 to 12 weeks to work. What? You know, 10 to 12 weeks, I can't wait. So you have to have that conversation at the very beginning. And you don't have that luxury sometimes in 15 minutes. So I'm preaching a little bit. Let me stop. Let me tell you about a real-world situation. A patient that I see him. I have a volunteer clinic, and so because it's a volunteer clinic, I don't get paid anyway. So I can spend as much time as I want with the patient. Okay, and well, you're looking funny. What's that? It's a volunteer clinic.
I'd like to be your patient.
Well, it's
I'd like somebody to have a lot of time.
It's something that where I work, they allow me to do that. It's a half day a week, and basically, this person came in, and an elderly woman came in with her family, and I met with the family and the patient in the very beginning. And the story was that she had treatment-resistant depression, so she had major depression that had not responded, according to them, you know, to many, many different treatments and different psychiatrists. They'd seen several different psychiatrists. So when she came to me, I took tried to take as good a history as I could, and I think it's probably spent 2 hours with them the first time I saw them, and the best history I could. And from what I could tell symptom-wise, she really had partially responded to what she just had been started on about 4 weeks ago. So I said, well, let's take this medicine and let's increase it a little bit, and let's give it another 4 weeks. I explained to them what to expect. You know, that you're not going to notice a difference probably in 4 weeks, a lot of difference anyway. The family might, but you won't. Sure enough, 4 weeks later, this medicine's not doing anything for me, doctor. I can't tell a bit of difference. The family says, you know, I think she's getting a little better. She's starting to come out of the room a little more and go out of the house a little more, starting to do her housework like she used to do more. Starting to get back to her old self. Not exactly there yet. And she had complained from the very beginning of a pressure in her head. And I tried to narrow it down or nail it down with her. It wasn't a headache, she said. It wasn't really painful, just the pressure. I mean, that's all she could explain. And she'd been checked, you know, for brain tumors and different things, and nobody could find anything. And she still was real tearful, especially in the morning, and depressed, you know, in the mornings. And then as the day went on, she'd feel a little bit better. So after that first 4 weeks, she said, no, I'm no better at all. The family said, she's a little bit better. I said, let's just give it some more time. Let's not tweak the medicine. She, of course, wanted to change the medicine and try something different. It's tough sometimes to say to somebody, no, you got to wait, you know. But we waited another 4 weeks. Sure enough, she was a lot better. And she even felt better, although she still said, Doc, you know, for about a half an hour every morning, I'm still kind of down. I cry a little bit, and I have this pressure in my head. I think we should try something different. Again, I resisted, and this time I said, you know, I'm thinking that we're about as good as we can get with the medicine. This is probably about all we can do, and you've tried about everything else, so I don't know what else to try. So I said, let me see you back next time for an hour, just you and me, and let's talk. And sure enough, as you know, we did this a couple times for an hour, and sure enough, it came out that she's always been what I call a stuffer. You know, never really. Well, before we can get to that, she has a whole bunch of guilt built up over the years about different things. Okay, one of the things that she was so guilty about, probably the biggest thing was, and I think it was some anger towards her husband too, that 3 years ago her mother had needed nursing home care, and it wasn't 3 years ago, it must have been longer than that. I can't remember, because she's in her 80s, so mom must have been, maybe it was 3 years, I don't know. But her husband said, no, you can't bring mom into the house. And she was saying, well, I promised mom I'd never put her in a nursing home. She had to put mom in a nursing home. And I don't blame the husband, because I think she was depressed. The patient was depressed. She probably couldn't have taken care of mom at home. So puts her in a nursing home. Of course, you know, mom eventually passes away 3 years after that, and she still, I swear she said it was 3 years, but anyway, for this whole time, she's never talked about that with anybody. And she had to be angry with her husband about it, I'm sure. She had said no, but I mean, I'm assuming she probably had some of that in there. But also just very, very guilty about that, about having to do that to her mother. She never, like I said, doesn't talk to anybody about that. And besides that, she doesn't talk to anybody about anything that upsets her. So if somebody says something that's hurtful, she won't say anything about it. Somebody gets angry, she won't say anything about it. If there's a conflict, she avoids conflict at all costs. She basically takes all of her emotions and stuffs them inside. Grins and bears it, right? And you know, she's from the old school. And that's the way society, I shouldn't say old school, because society still teaches that. It's not okay to cry, it's weakness, you know. When you have to urinate, is it weakness to urinate? No. It's a bodily sensation, a bodily drive, right? You know, if you have an emotion and you feel like crying, cry. You know, maybe there are some situations where you don't cry. Like, I wouldn't cry at the middle of the office in a big meeting, you know, probably. But maybe go to the bathroom and do it. I don't know. But anyways, she didn't think it was appropriate to cry ever. And, you know, so what would happen is, at least the way I conceptualized it, she would cry for these little periods in the morning, and it would relieve this pressure, and it would relieve her basically her emotions, you know, it let the pressure off, and she'd feel okay the rest of the day until things start to build up again, and by the next morning she was worse again. I tell people it's kind of like a pressure cooker, you know, with a little valve on it. Crying is like your valve, at least one valve. There's a bunch of different valves, but crying is probably one valve. If you clamp that valve down as tight as you can, what if you do that on a pressure cooker? What happens? Right, explodes. So, you know, I told her that, and I said, I think we have two options. It's not going to be medicine that's going to fix this. I think either you do some psychotherapy and you learn about how to kind of stand up for yourself, be a little more assertive, get your emotions out, and not be so afraid of conflict and afraid of hurting someone or anything else. Get stuff out little by little, and then it won't build up on you. Or just be okay with the crying a little bit in the morning. A half an hour every morning crying a little bit. That's not going to hurt anybody. You know, it's you know, probably safer than tweaking the medicine and adding all kinds of crazy medicines on board when you're 80-some years old, you know. So that's kind of where we stand at this point. I'm going to be curious to see what happens, whether she, you know, at 80-some years old, I can't expect her really to go into psychotherapy and start doing a lot of work, but we'll see what happens. Maybe she will, so we'll see. But you know, the other psychiatrist, it's not like I'm a super smart guy or anything. I just spent the time with her to sort that out. I mean, the other psychiatrists didn't take the time. They didn't have the time or didn't take the time. In 15 minutes, you can't get to that. First of all, she's not going to open up to you in 15 minutes. It took her probably 2 or 3 sessions of an hour to open up to me. And probably the family went in with her every time, you know, and she couldn't talk about that stuff in front of the family. So I think in an ideal world, it would be nice if there was the luxury of, if the system would reinforce good treatment and not necessarily the cheapest treatment, you know, the cheapest thing. Sometimes you get what you pay for, and I'm afraid sometimes, in psychiatry especially, that may be true. Okay, so that's that example. Any questions about that?